presentation of the same, and also the pathophysiology. So we majorly attributed our disease to an allergic process, where we said that once an individual interacts with an allergen, that will trigger an immune system, or rather an immune response from an individual, where we said that an allergen could be presented to a type of macrophage or a type of white blood cells by the name dendritic cells or the antigen presenting cells. So these are normally presented to the T helper cells. So in asthmatic individual, we said that one of the problems that you can see is actually having a mutation of TH0 to TH2. So ordinarily, if maybe you will have something like this, this type of cells will not be responsive to the dendritic cells that normally has some antigen presented on them. So they'll ignore this form of presentation and will not have these preceding reactions where we'll be releasing the interleukins that should otherwise stimulate the plasma B cells. But in asthmatic people, so one of the pathogenesis or one of the proposal is normally that these people could be having a mutation from the T helper 0 to the TH2. So the TH2 is normally very responsive or hyperreactive, in that when the allergen is presented, it is likely to respond. And the response is by production of several types of interleukin. So the interleukin will produce, or rather will stimulate the plasma B cells, sometimes the memory cells, to be able to produce the specific antibodies. When the antibodies are produced, specifically the immunoglobulin E, it is able to attach itself onto the mast cells. When it attaches itself onto a mast cell, it's able to degranulate the mast cells. So in the process of degranulation, producing leukotrienes, histamine, and other modulatory of inflammation. So the leukotriene and the histamine is likely to interact with the bronchus to be able to give us some of the major pathological changes that we expect in those who are asthmatic, where we are able to say the bronchial edema, hypersecretions that could result with a lot of mucus, and also bronchoconstriction. So that means the bronchial muscle at this particular area also can constrict, and that is because of these mediators that are being produced. Alternatively, you can also have the eosinophil being activated. So this is not usually immediate. This is normally like a late response, where the same leukotrienes, the interleukins that are being produced by the TH2 cells also has the ability to activate the eosinophils. So the eosinophils also has the ability to produce other factors or directly interact with the wall of the bronchus to give us these pathological changes that are clinical, that will give us the clinical picture of asthma, because we are saying somebody's experiencing difficulty in breathing or wheezing because we are having an occluded, or rather a diminished caliber. So caliber by way of deposition of mucus, or it could be by way of edema, or it could be by a way of bronchoconstriction. So this is what we anticipate. And we said that we suggested that this is very important also when it comes to drugs, because the same drugs will also be targeting some of these pathways, so that at least you are able to reduce the constrictions that we are seeing as a result of the pathological changes that we are being seen. So what we need to remember, allergen or the allergy plays a very important role in all this. And what we suggested as a result of these pathological changes that will be seen at the bronchus, we suggested that this has the ability to trap the air, the alveoli, that will be very characteristic when it comes to some imaging and to some other complications that we'll definitely discuss mostly in IMED. So in summary, it is good to remember that the pathogenesis of asthma is entirely or most of the time linked to an allergic process that induces an immunological response. So asthma is an immunological disease mediated by reagenic antibodies. So that is an IgE. So if you do some serum test for the immunoglobulin, in those who are allergic or in asthmatic people, you are likely to get an heightened level of immunoglobulin type A. So this is normally bound to mast cells, as we've been able to see in the airway mucosa. So when there's a re-exposure to antigen, it normally results in an antigen-antibody interaction on the surface of the mast cells, so which is likely to trigger the release of mediators that is normally stored within the cell granules or in the vesicle. So these mediators include things like the leukotrienes and the histamine, those which we've suggested in our diagram. So this has the ability to recruit other cells or activate other cells. So, again, other mast cells can be degranulated by the same cytokines or in mediators that are being released. They can also recruit other eosinophils and neutrophils. So we are not only experiencing an allergic reaction, but it is actually being expounded to incorporate some inflammation. So the inflammation that is very vital in this process that will be marked by edema. So that means that when this process is ongoing, you can have something chronic developing, which is majorly marked with the deposition of now these other cells, the neutrophils, the monocytes, the other macrophages that are being recruited because of the chemotoxic effect of these mediators that are being released. So these mediators released from cell diffuse through the airway and causes the constriction. So the bronchoconstrictions that we just saw is likely to be as a result of these mediators that is likely to cause the three major changes that we suggested: excessive secretion, edema, and the bronchoconstriction. That is with the muscle spasm. There'll be an increased permeability. So we know all the things that is likely to happen in the process of inflammation. So the same thing will be taking place locally within the bronchus to cause some distress, as we'll be able to see. So these mediators include histamine, leukotrienes, tryptase, and we have various types of leukotrienes, but not really a must for us to know, but we have the leukotriene C4, D4, and we also have the prostaglandin D2. So these are some of the mediators that are likely to produce in the process. Some are not entirely constrictors. Some might actually be dilators, but it is just that they are being produced in this inflammatory response. So the other mediators such as cytokines and interleukins are responsible for the sustained bronchoconstrictions, cellular infiltration of the mucosa, and the mucosal hypersecretions through activation of eosinophils and IgG production. So the bridge between the pathophysiology and the pathological changes, it's the mediators. So where the pathological changes, we are able to see the hypersecretion in our text. That is definitely likely to plug and cause an obstruction. We are likely to see bronchoconstriction. We are likely to see edema. So edema, the same mediators can increase the vascular permeability, and therefore we will be having fluid seeping from the blood vessel compartment into the interstitial area, so causing some form of edema. So all this is likely to result into, you can say, reduce caliber, of course, causing an obstruction. So the bronchial hyperreactivity is related to inflammatory of the airway mucosa, and increased eosinophils are seen with the polymorphonuclear leukocytes. So we are seeing an allergic, of course, with an inflammatory process. So the disease is likely to be chronic. And you now want to imagine a situation where you are having an ongoing inflammation that has been persisting for a very long time. One of the features of the chronic inflammation that maybe you might have known should be something like the fibrosis. So suggesting that in as much as we are having these pathological changes, the hypersecretions, maybe the bronchoconstriction, and definitely edema that is eating onto this caliber. So when the inflammation persists, fibrosis is likely to take place. And when the fibrosis takes place, it means that it might be difficult to restore the normal caliber. So it might give us some aspect of irreversibility. Even though in our introduction, we say that one of the features that you expect with asthma is for it to be reversible. So this is true mostly for acute asthma, or it might be reversible to an extent, but you might not be able to achieve full reversibility. This is especially when if you are having an ongoing chronic inflammation, whereby some of the features of chronic inflammation could be through fibrosis deposition. And when that is the case, it is we are not likely to achieve full reversibility. So to an extent, it will be reversible. So irreversible in respect to our original maybe diameter of the caliber. But when you give drugs, it will be reversible to an extent, but not fully reversible. The reason why it might not be fully reversible, sometimes it could be because it's chronic. And when it's chronic, you could be having some deposition of fibrotic tissues. So functionally, you can also classify asthma as such, even though we've agreed in our context that asthma for us will represent something that presents with some bronchoconstriction or something that is likely to have a similar pathological pattern, even though in IMED we'll be able to see that actually there's a clear distinction between the asthma and the other COPD or other obstructive lower respiratory tract obstructive disease. Otherwise, you can also classify asthma as extrinsic. So this is normally associated with identifiable allergic factors. You can have intrinsic asthma, where sometimes there is no any obvious insult from the environment. You can have exercise-induced asthma. You can have asthma associated with COPD. So this is even more likely when you are having now the allergic attack with some form of COPD, such as the bronchitis or the emphysema, because we suggested that they are also likely to take a similar pathophysiological pattern. So we'll be able to see when covering the COPD. But this is just to note that people with COPD, maybe they could just be okay, but their symptoms could also be dependent on the environmental triggers. And they'll just present as those who have asthma. So in some literature, we used to classify COPD as bronchitis, emphysema, and also incorporate some chronic asthma, which made a lot of sense considering now the fibrotic aspect in the pathological changes that you are likely to see in the wall of the bronchus. So when you are treating asthma, you should be able to set up some goals. So you need to remember that when treating asthma, so you want to tailor your treatment to the individual. That means you give them what respond to this individual. So rather than just saying that you need to start with a certain drug, even though that is recommended. Start as you scale up or as you scale down, but you'll be able to see that individual responds differently. So some might respond to a certain drug, some might respond better to a certain drug. So you make sure that you individualize the treatment, and the only way you are able to do that, of course, is by asking the history. So maybe you might want to know what individual drug, the patient normally uses in their previous attack, what worked for them, what did not work for them, so that you give the treatment appropriately. So your aim is also to prevent morbidity and mortality by reducing the emergency care, hospitalization, and prevention of nocturnal symptoms. We've suggested that asthma is a chronic disease. So some of the drugs that we'll also be using will be referred to as the preventers. Just a minute. So I was suggesting that in the course of treatment, we'll not only be maybe controlling or maybe arresting the symptoms, but also with the pharmacological drugs, we should be in a position to be somehow be able to prevent the disease. And by prevention, we'll be minimizing maybe hospitalization and also maybe preventing the worst presentation in terms of the disease. With the drugs, we are able to improve the quality of life. This is by decreasing tolerance of physical activity and improving self-image, and decrease the loss of time at work and school. So when a person or an individual is in good control with the drugs, it means you can be able to increase the time in relation to work and also school. Another goal is reversal of the airflow, obstruction and improvement of the pulmonary functions, prevention of the airway inflammation, optimal asthma control, utilizing the least amount of medication. You want to do adequate monitoring. You want to educate the parents and patients. Your education mostly revolving around maybe how to use the drugs, how to prevent the allergens, and maybe how the parents or how your surroundings should be able to support you at least in minimizing the recurrence of these symptoms every now and then. So how do you manage asthma? Of course, for us, our focus is with the pharmacological aspect, but you might not be able to achieve that if you ignore the environmental control. So that means the house should always be clean. These are individuals who are advised to avoid pets, especially with fur or feathers. They are advised to wash the beddings weekly in hot waters, encase the mattress, pillow, box spring in dust-proof covers. So these are part and parcel of the education, what you need to educate the patient plus maybe the parents. And of course, in so doing with the medication, you should also be in a position to monitor the lung function, so that at least you are able to tell whether these patients are getting better or not. Also, because we've said that asthma can also be chronic. And when it is chronic, it means that you can be having a chronic limitation in terms of breathing. So it is actually very important to be able to monitor that. And also the medication, which will now be our area of focus. So medication or otherwise the asthma therapy. So largely this one is normally divided into two categories. So while using drugs to individuals who are asthmatic, so you can have your therapy into short-term relief or long-term control. So anytime you are using a medication that is channeled towards asthmatic people, you need to be sure, or you need to categorize your medicine, whether you want just an immediate symptomatic relief. So that is with the short-term relief, or maybe you want a long-term control. So long-term control could be very important. This having that these are drugs that normally prevents an individual from getting maybe recurrent attack. So you are controlling the symptom now, and then you also need to use a drug that maybe will prevent the symptom from recurring. So these are actually very important. So what do we mean when we talk of the short-term relief? So this is mostly effectively achieved by bronchodilators. So these are agents that are able to dilate the bronchus muscles. So these include the beta adrenoreceptor stimulants, the diofulin, and the antimuscarinic agents. So this normally increases the airway caliber by relaxing the airway smooth muscles. And we also have the long-term control. So these are majorly thought to be anti-inflammatory agents, which include corticosteroids and mast cell stabilizer. For example, sodium chromoglycate, even though we'll be able to see that. So any medication, you categorize it whether it's a short-term reliever or it's a long-term controller. So how do you classify the medications that are used in asthma? So we have the bronchodilators, and in the bronchodilators, we also have some other types of bronchodilators. So these are the sympathomimetic agents or the adrenoreceptors. So as the word suggests, they act by increasing the sympathetic activity. So this might include adrenaline and many things that mimics that. We also have the methylxanthines, and we also have the antimuscarinic agent as bronchodilators. We can also have anti-inflammatory agents. So these include corticosteroids. We also have the mast cell stabilizers. We can have something like sodium chromoglycate. We also have the antihistamines, even though they don't play a major role in terms of controlling the asthma. We also have other leukotriene inhibitors or other drugs such as leukotriene inhibitors, leukotriene receptor antagonists. So this is where you can have things like montelukast. So the antihistamines are things like cetirizine, Spiriton, and many other types of antihistamines. So this is the major classification. And then from this, we can now maybe explore maybe the individual drugs. But so we are starting with the bronchodilators. So this is just in terms of expounding. So we said that bronchodilators, we have three types of bronchodilators: the sympathomimetic, methylxanthines, and the antimuscarinic agents. So the sympathomimetic, these are drugs that are likely to increase the sympathetic activity. And they can also be further subclassified depending on the receptors with which these drugs are likely to act on. So we have the alpha and the beta adrenergic agonists. So these include epinephrine and ephedrine. So these are drugs that works indiscriminatory without regarding the specific type of adrenoreceptor. So they act on both alpha and beta. So example include epinephrine and ephedrine. So we have those that act specifically on the beta receptors. That is the beta 1 and the beta 2. They can be regarded as the beta 1 and beta 2 stimulants or agonists. Example include the isoprenaline or piprenaline, as a brand name Alupent. So we have this specific selective, that is the beta 2 selective agonist. Can be either short acting or long acting. So remember, the short acting, you want immediate relief. The long acting is good for controlling. So example of the short acting, this is where we have the salbutamol, terbutaline, isotherapine, formoterol, metoprolol, and also pabuterol. So the short acting are normally good for acute attack, because when you are having an acute attack, your major goal is to achieve immediate symptomatic relief, and you are only going to achieve that using a short acting drug. You can also have some long acting. These are good for night attacks, or they are good for maybe controlling or even preventing subsequent attacks. So, but you'll be able to see that some of these long acting might also have the property of having immediate relief. A good example is the formoterol. So, in as much as it's a long acting drug, it is also a fast acting. While something like salmeterol, it's a long acting and a slow acting. So that means that when you're having an inhaler which has the salmeterol, some other compound, mostly a corticosteroid, you might need to have another inhaler just in case of acute attack. But with the formoterol, which is a long acting and at the same time fast acting, you might not need a reliever or a short acting drug because it also has the ability to act faster, and in so doing it will also be able to act on acute attack. But generally long acting are good for night attacks or for preventing. So this include majorly salmeterol and the formoterol, so which are normally available as inhaler. Even the short acting, most of these are available as inhalers. We also have other group of drug with the bronchodilator, methylxanthines. So we'll be able to see that these act through the camp, as we suggested, the phosphodiesterase. So these are aminophylline, diaphylline. We also have the antimuscarinic agent or the anticholinergic. So this is another time where we are having anticholinergic drugs reappearing. So example, atropine, not normally used nowadays because of the many side effects. We have the ipratropium bromide. So ipratropium bromide is the most common amongst these antimuscarinic. We can also have the oxytropium bromide. Otherwise, ipratropium bromide is the most common in the muscarinic. The long-acting fairly salmeterol and formoterol are both common. So in this one, we have the salbutamol and terbutaline as the most common, while this epinephrine and ephedrine are anti-inflammatory agents, majorly corticosteroids, even though corticosteroid will recur in both ANS and endocrinology. Examples include beclomethasone, hydrocortisone, prednisolone, dexamethasone, and budesonide. So this has the ability to limit the inflammation by reducing the responsiveness of the mediators that are likely to release by the mast cells. So that means less recruitment of these other white blood cells, and also less inflammatory activity. We also have drugs that are referred to as mast cell stabilizers. So when you use a mast cell stabilizers, even if your IgE interacts with the mast cells, they'll not be able to granulate. So this prevents the degranulation. An example of this drug includes sodium chromoglycate and the nidochromyl sodium. So what I want you to do is that all these major classification of the anti-asthmatic drugs, you relate it to the pathophysiology that we proposed. So you'll be able to see that all are making sense. Antihistamine, of course, we are targeting the one of the mediators as the histamine that was released. So if you use the antihistamine, theoretically, you'll be able to minimize the pathological changes that you anticipate to find in the bronchus. We also have other drugs, so that leukotriene inhibitors. So these are also very common, even though somehow expensive to most patients that you are likely to encounter. So these include things like montelukast, zafilukast, xylitol. They specifically antagonize the leukotriene. We've seen that leukotriene and histamine are some of the mediators that are likely to be released by the degranulated mast cells. So actually very important. So that is the classification in terms of the drugs as an umbrella. So you can also have clinical classification. This is just to know which drugs to use when there's an acute attack, which drugs are good for prevention, which drugs are good for what. So as we've suggested, we have drugs that can be used in the acute attack. So in our bronchodilators, we mostly prefer those that are normally short-acting. And we also suggested that some long-acting drugs, bronchodilators, that is specifically the sympathomimetic, could also be used because some are actually fast-acting. An example is the formoterol. So drugs that are normally used in acute attack, salbutamol, which is normally in inhaler. Some can be available in injectable, but mostly in the market, you are likely to find the inhaler. You can also have the tablet preparation, even though tablet is not normally used for acute attack. It is normally good for prevention, especially if your patient is not able to afford other anti-asthmatic drugs. So you find that it is not preferred because of many side effects, most of them including tachycardia. So you also have a terbutaline. Terbutaline also a short-acting bronchodilator under the sympathomimetic, specifically the beta-2, also available in inhaler. We have aminophylline that can be available in IV or suppositories. So this is one of the methylxanthine drugs. We are having the ipratropium inhaler, can also be good for acute attack. So we suggested that this is an anticholinergic. We also have a corticosteroid that can be used for acute attack, normally available in injectable form most of the time. This is hydrocortisone. You can have adrenaline. Adrenaline in this context is normally preferred subcutaneously or normally administered subcutaneously. So these are some of the drugs that can be used in acute attack. So depending on what the facility is having, according to the cost, you are likely to find this. But most of the time, you are likely to have salbutamol or the Ventolin, which can be administered as an inhaler through nebulization. So we'll be able to see a clear distinction as it relates to either the nebulization or the inhalation. So we also can classify to have some of the drugs that can be used in the prophylaxis of asthma. So we said that an individual presenting with an acute attack, you'll want to use drugs quickly to control their situation. And then afterwards, you will think of how do I prevent this from recurring? Of course, you can tell them to avoid the allergen, but sometimes or most of the time, the immunological response has been activated. So while you are maybe minimizing the constrictions that the patient is presenting with, they are definitely likely to re-experience the same situation, even minus exposure from an allergen. So it is normally good to think of preventive drugs. So some of the preventive drugs that you can administer to your patient are salbutamol in tablet form. You can have terbutaline, again in tablet form. You can have ephedrine and theophylline, normally in brand name, the Franol. You can also have aminophylline slow-release tablets. You can also have the salmeterol inhalers. It's one of the long-acting but slow-acting. Formoterol, we said that it can also be very important in acute attack because it's a fast-acting but again long-acting drug. So most steroidal inhalers or corticosteroid inhalers are normally used in the prophylaxis or in the control of asthma. So not preventing asthma in those who have never had asthmatic attack, but those who have had maybe increased frequency of these asthmatic attacks. So you might want to use a drug to prevent maybe the next, because sometimes you never know how it might come. Because remember, you are threatening the way an individual is breathing. So it normally requires an emergency response. So how do you normally administer drugs in asthma? So we have various ways of administration. So we can have inhalation and nebulization, and we can, of course, have the oral form and many other ways of administration. But just to incorporate this, so most of these drugs or some of them are likely to be compound in different form. So meaning that they can come in some powder form, pressurized powder form that can be either in powder form or in some liquid form, pressurized, that can be administered through inhalation, or some liquids that can be administered through nebulization. So we'll be able to see maybe the slight difference. So pressurized aerosol inhalers is an effective and convenient method of administration for mild to moderate airway obstruction. Aerosol inhalers usually act for around 3 to 5 hours. Aerosol inhalation provides relieves more rapidly and causes fewer side effects than tablets. So you find that these methods are actually preferred because they can be able to minimize side effects. Because remember, through inhalation and nebulization, you are administering drugs directly to the lungs or to the bronchus. And the systemic effect of the steroid use, the drug is relieved, the drug is delivered directly to the bronchi and is therefore effective in small doses. So rather than giving a lot or more doses in oral form, because remember the metabolism and many other things that the drug is likely to be subjected to, you'll rather just administer a small quantity that goes directly to the bronchi. So remember, one of the distinctive factor between features maybe between inhalation and nebulization, you need to mark this. So it's mostly preferred for mild to moderate. So this is specifically through inhalation. So you'll prefer to use this in those who have mild to moderate airway obstruction. So if the obstruction is very severe, you might consider nebulization, because nebulization represents much more quicker delivery and delivery of big particles. So let's proceed. Inhalation mode of delivery, the drug must be converted into particulate matter or form of optimum particle size of about 2 microgram that is delivered to the bronchi. The drug is then delivered to the lungs as an aerosol, disposed as a gas, which can be produced by pressurized inhalers and nebulizers. So let me see if we have a picture of the same. So let's go into still inhalers or pressurized aerosol. So the drug is dissolved in a low boiling point liquid in a canister under pressure. Opening of the valves of the canister releases a meter dose liquid that is ejected into the atmosphere. The carrier liquid then evaporates instantly, leaving an aerosol, the drug to be inhaled. So this is also another crucial point, especially when it's come to maybe the education. So how do you educate patient in terms of maybe inhaling? So it is actually very important for coordination of the activation of the inhaler with the inspiration and the final holding of the breath to ensure optimal delivery of the drug. So this is crucial to successful use of the inhalers. The young children and elderly subjects who have maybe difficulty coordinating inspiration with the canister opening are normally advised to use spacers. So spacers can be good in pediatrics and in the elderly, where might have those who might have difficulty in holding the canister while taking or having a deep breath. So the spacers acts as the aerosol reservoirs, reduces the impact of the aerosols in the oropharynx. So this is the inhaler. So the drug is compound in this canister over here. So while an individual is inhaling, is normally held in an upside down manner. So where you have this area attached to the mouth. So while pressing this area or while pressing the canister, it should be able to release some drugs. So just like in a way of spraying. So you are pressing this area and it will be able to release some gas or rather some drugs. So while pressing, the individual should be breathing in so as to allow the drugs to be delivered into the lungs. So that is the coordinating we are referring to. A child might not be able to coordinate that. So rather than just placing their mouth directly, they might need a spacer to be able to coordinate that. So an elderly or pediatric patient might need a spacer rather than using this directly. So this is an inhaler. So the drugs could either be in powdered form, but most of the time liquid, so that while pressed, they'll be released under a lot of pressure. So we can have the sharp difference between inhalers and the nebulizers, in that nebulizers are likely to deliver even these drugs at a more speed compared to the inhalers. So that's why we are suggesting that in the nebulization, you're likely to nebulize those who have moderate to severe form of bronchospasm. So nebulizers convert solutions or suspension of the drug into an aerosols. So there are two types of nebulizers. We have the jet nebulizers and ultrasonic nebulizers. So jet nebulizers requires a driving gas, usually from an air compressor. The solution in the nebulizing is broken into droplets of the jets, and larger droplets are filtered off, leaving small off to be inhaled. So we can also have the ultrasonic nebulizer. So these are just based on the classified in terms of what are the powering device, because we know that the jet nebulizers, you can have the electrical or the ultrasonic nebulizers. So that is just in terms of what is powering the nebulizing machine. But at the end of the day, you'll be having your solution transformed into some air droplets that can easily get into the lungs or into the bronchus. So these are just a few types of the nebulizers where it is normally fitted into a nebulizing mask. So this is a mask. You are placing your drug somewhere here. So maybe think of a Ventolin solution. And this is just, this is now the nebulizer. Or maybe think of it as something that is able to generate power to be able to convert this solution into droplets. So think of this as maybe something like a generator. So this is normally connected to electrical power point. So we have this electrical or the jet type, or we also have the ultrasonic and many other forms, depending on the sources of power. So what is the advantage of inhalation? So why prefer inhalation over orals or over injectable? So what are the advantage? It delivers the drugs directly to the bronchi. So that's a good thing to the patient, in that you can be able to minimize the side effects. And when it comes to the drugs, the pharmaceuticals who are compounding the drugs will not need to compound the drug at a high dose. This is because just a small dose is actually enough when they are administered through the inhalation. So that is the advantage. So inhaler is normally preferred compared to tablets or injectables, in that it's likely to provide a rapid relief, considering that the drug is just administered directly. We have the metered dose inhalers are used. These are effective in mild and moderate airway obstruction, the way we've suggested. So salbutamol, terbutaline, and some other drugs might come as inhaler. Duration of action is normally 3 to 5 hours, so they can act maybe between 3 to 5 hours before an individual get another attack if it is inevitable. So we have the phenytoterol, which is less beta-2 selective than salbutamol. Inhalation is done slowly and holding the breath for 10 seconds before breathing out. So while we suggested that while you are pressing on the canister, the patient should be able to breathe in through the mouth, and they are advised to hold the breath for around 10 seconds so that the drugs can adequately interact with their lungs. So we also have the nebulizers as we suggest. So what are the indication for the use of nebulizers? At what point will you want to use a nebulizer? When you want to deliver a drug at a much higher dose, that's why we've suggested that nebulization is mostly conserved to those patients who are not, who are maybe having severe bronchoconstrictions, especially those who are not responsive to the inhalers. You'll definitely want to nebulize the patient. Not and when you want to nebulize, it is not like you are changing the drug because maybe say you're having a patient who maybe you've given salbutamol inhalers and they are not responsive. So how do you increase the dosage or how do you increase the delivery? Is by preferring another mode of delivery, which is nebulization. So nebulization is likely to deliver a lot of dose compared to the standard inhalers. So you'll also prefer nebulizers, of course, if you want to convert it into aerosols. So usually used to deliver beta-2 stimulant solution to patient with acute exacerbation of asthma. So beta-2 stimulants are the things like salbutamol, terbutaline. Used in severe asthma, where regular dose is required, the patient should have shown that she or he can benefit from higher dose of the inhalers. So used for children who cannot use standard inhalers, the medication should be could be any drug. So what we are suggesting that in an emergency context, sometimes when the presentation is mild to moderate, you can institute an inhaler before going to use a nebulizer. So if you're dealing with children who might not be able to use the inhaler, just go to the nebulizer direct. So it can also be an alternative way for delivering some other drugs, some other antibiotics, such as pentamidine, that is normally used in the pneumocystis jirovecus or the carinis. The dose of the salbutamol respiratory solution. So this is the dose. So normally the preparation is in 5 milligrams per ml bottles, could be in the 10 to 15 mLs. So the dose is 2.5 to 5 milligrams per dose of nebulizer. So this can be given up to 4 times a day, depending on the situation of the patient. So what are the approaches to treatment? So we largely respected that we are not only using the drugs, but we also want to control the environment. So you control the environment, you want to achieve adequate relief, and of course you want to prevent future recurrences. So what are the approaches? So this is the logical format: prevention of the exposure to antigens, reduction of the bronchial inflammation and hyperreactivity, and of course dilatation of the narrowed bronchi. So this is what this is how you want to approach. So how do you achieve the prevention of exposure to allergens? So this is prevention of the exposure to allergen is important in extrinsic asthma. This is because we suggested with the extrinsic asthma, there is an identifiable cause. It is important to identify that the allergen, through history taking, provocation tests, with the view of avoiding them. It may involve even the change of occupation and workplace. So this can be very important. You'll also want to reduce the bronchial inflammation and hypersensitivity, and this majorly involves the use of drugs. So the first drugs that we'll cover, but just in brief, because they'll be reappearing in endocrinology. So corticosteroids, anti-inflammatory. So these are drugs that normally relieves the inflammatory process in the airway mucosa, as well as reducing the responsiveness and hypersecretion of the mucosa. So corticosteroids are normally lipophilic compounds that are well absorbed and effective when given orally, intravenously, or even topically. Corticosteroids are primarily metabolized in the liver before excretion in urine as maybe glucuronides, sulfates, or even unconjugated compounds. So what are the mechanisms of the corticosteroid drugs? So they generally reduce the inflammation via inhibition of the production of the inflammatory cytokines. So these cytokines were very important in the recruitment of some other macrophages or some other white blood cells. They can also inhibit the influx of inflammatory cells into the lungs following an explosive on an exposure to allergens. Of course, this is also again achieved by minimizing these cytokines. They can inhibit lymphocytic and eosinophilic airway mucosal inflammation of the asthma. This is especially in the late response. So they also have the ability to suppress the activity of the lymphocyte and the eosinophils. They are likely to reduce the microvascular leakage caused by mediators of the inflammatory cells, or rather the again cytokines. Again, this is achieved by limiting the cytokines. They can also potentiate the effects of beta reception agonists. So what you need to note, they increases the sensitivity of the beta receptors to the beta agonists. So this is in terms of how these corticosteroids are generally likely to work. So the corticosteroids in our clinical classification, we are able to suggest that there are some corticosteroids, including hydrocortisone, that are normally preferred for acute attack, while most corticosteroids are normally preferred for prevention or for long-term control, because sometimes for you to control the inflammation, you might not control the inflammation just immediately. So you might just require drugs to limit the inflammation that is likely to be an ongoing process. So corticosteroids are effective in improving all the indices of asthma, such as maybe the severity of the symptoms, test of the airways calibers, bronchial reactivity, frequency of exacerbation, and quality of life. So in a summarized way, you will want to use it to control, to prevent, and also relieve most of the time. That is by the use of hydrocortisone. So what are some of these drugs? So most of these drugs are preferred if they are given through maybe directly, either mostly through inhalation. This is because corticosteroid ones used systemically, they have a lot of many side effects. So it's rather if you can just give this drug through inhalation. But you'll see that in some severe case, some systemic administration of the drugs might be preferred. So majorly that is likely to be through oral administration. So example of such corticosteroids are beclomethasone, budesonide, flunisolide, fluticasone, triamcinolone. So these are lipid-soluble corticosteroids. So these allow delivery of corticosteroids to the airway with minimal systemic absorption. So your goal is to deliver the drug directly to the lungs, because you want to limit a lot of side effects. So for to understand the side effects, just remember our physiology of the cortisol, where these drugs could be a representation of exogenous cortisols. So the same physiological effects that we saw with the corticols are likely to be the same effects that we can see with now corticosteroids. So that might think of this as a maybe an overly increased level of cortisols. So some of the effects, not some of the effects, some of the drugs, the systemic steroids, and we have the inhaled corticosteroid. So we said that initially you might want to give your patient inhaled corticosteroid unless the situation or maybe unless the condition is so severe. You might that's when you might just give the systemic steroids, having in mind that they could be having the side effect. But one of the most common systemic steroids that is normally used in acute attack is normally the hydrocortisone. Of course, it is just given as a start medication. So example of systemic steroids, so this could be oral or injectable or 2 IM. We have hydrocortisone normally given as 100 milligrams. We have prednisolone and prednisone. We have the cortisone. We have the dexamethasone, and we have the betamethasones. Inhaled corticosteroid, we have the beclomethasone, we have the budesonide, and we have the flunisolide. So these are the dosages that that have been displayed. So beclomethasone normally given can be given twice, thrice, or even 4 times a day. We have the budesonide and we have the flunisolide. So what are some of the systemic effects that you can witness with the steroids? So we are, they can be arranged based on the systems. So this again is similar to what you can see in the cortisol. So musculoskeletal, it can cause myopathy, osteoporosis, aseptic necrosis of the bone. So why you are covering this side effect is that as a controller drugs or drugs that are used for control, they are not a one-time medication. They are likely to be administered for the longest time, not less than 6 months or 3 months most of the time. So that means where you might need to subject your patient continuously to a drug, you might want to use a drug that has less or minimal systemic effects. So these are some of the systemic effects. So musculoskeletal, the GIT could be peptic ulceration, gastric hemorrhage, intestinal perforation, pancreatitis. CNS could be some presenting with some psychosis or psychiatric disorder. Ophthalmic, patient might develop glaucoma or cataracts. CVS, these people might have hypertension, edema, hypokalemic alkalosis. Metabolic, it might precipitate diabetic mellitus, hyperlipidemia, obesity. In endocrine, it might present with growth failure, secondary amenorrhea, might suppress endocrine functions such as those of the hypothalamus, pituitary, and the adrenal glands. It might delay healing, and it might cause tissue atrophy. In the immune, it might suppress the immune system. So we have many of the unwanted systemic side effects. So we also have muscle stabilizers. So we said that these are normally two, sodium chromoglycate or chromoline sodium and nidochromyl sodium. So these are drugs that has the ability to stabilize the muscles. So when the muscles are stabilized, it means that their tendency to degranulate actually reduces. So these two drugs are stable but extremely insoluble salts. When used as aerosols, metered dose inhalers, they effectively they effectively inhibit both antigen and exercise-induced asthma. Repeated use, that is up to 4 times, reduces the overall level of bronchial reactivity. So both drugs have no effect on the airway smooth muscle tone. Of course, this is because they are just acting on the mast cells. So one of the drugs are sodium chromoglycate. So this drug is likely to impair the immediate response to allergen by inhibiting the release of mediators from the mast cells. Because we suggested that the game changers are the mediators that are likely to be released by the mast cells. So this drug, sodium chromoglycate, will prevent that. It also inhibits bronchial hyperreactivity. It plays a crucial role in the extrinsic asthma because mast cell degranulation sits at the last end of the pathway, where after mast cell have been degranulated, you release now the mediators. The mechanism of action, how they're able to achieve that? They do so by altering the cell membrane function, by delaying the chloride channel inhibiting cellular activation. This action on most cells results in early inhibition of response to antigen challenge, as well as inhibition of the eosinophil inflammatory response to inhibition of allergens. So this also affects cells and not only mast cells. So think of stem cells and not only mast cells. So this is by delaying the chloride channel. Pharmacokinetic, it is poorly absorbed from the gut. It is administered by inhalation or by inhibitions to drugs. It is not metabolized, and therefore it is excreted and changed in feces and in urine. Administration through metered dose inhalation or maybe through nebulization. It can be taken 2 puffs, up to 3 times, or as an ampule for nebulization, up to 3 times. So maybe it can be very important to always be checking any type of inhaler. Just try to know that 1 puff contains how many dosage in terms of maybe microgram or milligrams, so that you as an individual, you can able to say, I want this patient to take 2 puffs or 4 puffs at a go, depending on the dosage that is contained in every puff. So away from chromoglycate sodium, we have the nidochromyl sodium, also poorly absorbed from the gut, and therefore it is given as an inhaled aerosol. Has a similar action to the chromoglycate. Indication in the treatment of mild to moderate asthma, and it can also be very important in the prophylaxis, because if you're having your mast cells stabilized, it means that there's no way you'll get the allergic response. We have the antihistamines. We've seen that their role is not normally very significant in asthma. So the H1 receptor antagonists lessen asthmatic symptoms through direct inhibition of the histamine-induced bronchoconstriction and inhibition of histamine-induced effectors, inflammatory mediators. They are considered adjunctive therapy, since histamine is not the only mediators responsible for the clinical manifestation of asthma. So we have histamine, leukotriene, and others. So example of such antihistamines include ketotifen, an antihistamine which acts via H1 receptor blocker. It has some anti-asthma effects, and where it is used as an anti-allergic agent, it is important in the asthma prophylaxis. So that is the dosage. We also have the tafenadine as also antihistamine. So we also have the bronchodilators. because our aim is also to dilate the bronchus. So I want to know if there is any question the bronchoconstriction. So those that act via the phosphodiesterase inhibition and the methylxanthines. So these are the theophylline. We also have bronchoconstriction can be inhibited by the muscarine mutagenesis and the adenosine antagonist. So this is the diagram that you can see. So for us to achieve bronchodilation, we definitely require an increased amount of the CAMP. So CAMP is likely to be increased by AC or the adenylate cyclates that is normally increased by when the beta receptors are activated. Such which are able to activate the beta receptors are the beta agonist. Increasing the AC, increasing the level of CAMP, causing the bronchodilation. So the CAMP is normally degraded by phosphodiesterase into AMP. So if you are able to inhibit the phosphodiesterase by use of methylxanthine such as the theophylline, you are likely to have the level of CAMP increasing, so causing bronchodilation. So we also have drugs such as the muscarine antagonist. So that means that acetylcholine has the tendency to cause some bronchoconstriction. So therefore, if you want to reduce the bronchoconstriction, you use something that will antagonize the acetylcholine. So this is where we're having the anticholinergic drugs or the anti-muscarinic drugs or the muscarinic antagonist. Also, this is a potent vasoconstrictor. So theophylline also has ability to prevent adenosine from acting with the bronchial wall, and therefore will prevent bronchoconstriction. So from this, we are able to see our major types of bronchodilators. The sympathomimetic, acting through the beta agonist. We having the methylxanthine, the theophylline, and we are having the anticholinergic or the muscarinic antagonist. Various names referring just to the same thing. More precisely will be the anti-muscarinic. So it is from this sense that you are able to appreciate our bronchodilators. So we have the corticosteroids, or those that controls the inflammations. We have the mast cell stabilizers, and now we are having the bronchodilators. We also explore the antihistamine. So we have various types of the bronchodilators. So these could be sympathomimetic agents. So these act via the use of beta-2 receptors. So when the beta-2 receptors are activated, they are likely to increase the level of adenylyl cyclase or stimulate the adenylate cyclase, therefore causing the CAMP to increase. So when the CAMP increases, it causes the relaxation of the airway, or rather we are likely to achieve the bronchodilation. So we acknowledge that sympathomimetic can be divided according to the receptors which they are likely to impact. So we have those that can act on both alpha and beta. We have those that act specifically on the beta-2. So we'll want those that act on the beta-2 when it comes to the asthma. So example of the beta adrenoreceptor agonists, we have the adrenaline or the epinephrine, which is a bronchodilator, vasopressor, cardiac stimulant, and adjuvant to local anesthetic, topical anesthetic, and topical anti-hemorrhagic and anti-glaucoma agent. So this is just acknowledging the other pharmaceutical or the pharmacological role of the epinephrine. So this is normally a very effective, rapidly acting bronchodilator that can be given through normally through nebulization or through subcutaneous administration. So you normally administer around 0.5 mLs of the concentration of 1:1,000 solution. So we have various concentration of epinephrine. So the two most important is normally 1:1,000, and you are 1:10,000. So if you nebulize somebody with this or give subcutaneous injection with this, somebody might not respond adequately. So you always need to check the concentration of your adrenaline. Is it 1:1,000 or 1:10,000? You'll prefer to use 1:1,000. So at the ward, when you interact with the drugs or with the emergency drugs, those who are now in the casualty, it is always good to check. So which one can be used for resuscitation and which one should be used for nebulization. So this drug can stimulate both alpha and the beta receptors. The mechanism of action, adrenaline act on both beta and alpha receptors on the effector cells, and thus causing vasoconstriction, bronchodilation, and increases the heart rate. So our major concern here is the bronchodilation. So we are just mentioning this to be able to see that you can also be having some other side effects. And of course, likely to cause some cardiac arrhythmias. Pharmacokinetic, of course, this is a neurotransmitter endogenously with a very short duration of action, shortest acting of the sympathomimetic drugs. After passage of transmission, is normally reuptaken to or normally retaken to the up to the storage side. That is sympathetic nervous ending and the adrenergic tissue. So this is more of the endogenous. The other part will be metabolized by the catecyl O methyltransferase and deaminated by the monoamine oxidase or the MAO. It is taken up by the sympathetic nervous ending and the adrenergic tissue, such as the bronchi, blood vessel, and the heart. Maximum dilatation is achieved 15 minutes after the injection. So this is where normally you can administer up to 3 dosage of adrenaline, mostly 15 minutes apart. So if there is no adequate response after the first dose, wait for 15 minutes, reassess. If not, administer again, wait for 15 minutes. If not responsive, again, wait for 15 minutes, administer. If up to the third dose maybe not as effective, think of some other bronchodilators or other ways of administration. What are the uses of adrenaline or epinephrine? Of course, it is used to provide a rapid relief in hypersensitivity reaction and congestion in bronchial tree, relief of moderate to severe bronchial asthma, in treatment of cardiac arrest, relief of respiratory distress, restoration of blood pressure in anaphylactic shock, to control superficial hemorrhage in the skin and mucous membrane. So this is by vasoconstriction, and it can also prolong the action of the infiltration of the anesthesia. So these are just other usage of the epinephrine. At the administration, it can be given subcutaneous after every 20 to 30 minutes, but averagely can give it even 15 minutes, still acceptable. So that which we are using is the 1:1,000 solution. So always be sure to check. A drug interaction, it can have some it might interact with anti-diabetic agents in that it might reduce the effectiveness. So remember, in the breakdown of glycogen at the liver muscles, beta receptors, once stimulated, they can increase the breakdown of glycogen, giving us a lot of glucose. So that means minimizing the effect of the anti-diabetic agents. They can also interact with the antihistamine, thyroid hormones, tricyclic antidepressant, and cause some severe cardiac effects. Precautions: elderly patient over 50 years, patient with heart disease, hyperthyroidism, hypertension, diabetic mellitus, those who have Parkinsonism. Contraindication in all types of shock except anaphylactic shock. Organic heart disease, cardiac dilatation, cardiac arrhythmias, extremities in local anesthesia, in that it might cause tissue necrosis. Adverse effect, sudden death if given through IV due to ventricular fibrillation. Tissue necrosis due to vasoconstriction can cause anxiety, tremors, arrhythmias, tachycardia, palpitation. It might worsen angina, cause mild hypertension, headache, sweating, and some other GIT symptoms. So we also have ephedrine, likely to have similar mode of action just as adrenaline. Indications are indicated for reversible airway obstruction. So one of the causes of airway obstruction reversible is asthma. We also need to be cautious in those who are hyperthyroidism, diabetic mellitus, ischemic heart disease, hypertension, renal insufficiency, elderly, or those who are having benign prostatic hypertrophy, the BPH, because it might cause an acute renal retention or urine retention. Side effects include tachycardia, anxiety, restlessness, insomnia, tremors, dry mouth, and cold extremities. So we also have other types of sympathomimetic, but this time round, we are dealing with the more selective to the beta-2 receptors. So any question?